In this video, we'll look at some diseases of concern for the EMT. We'll look at some of these. This is a table out of your book, Table 2.1, which are communicable diseases. And we'll talk in the last video about the difference between infectious diseases and communicable diseases. Remember that communicable diseases are those that are passed from person to person. Not all infectious diseases are communicable diseases. For example, Lyme's disease, you can only get from the tick vector, not from person to person. So first we'll talk about hepatitis B. Hepatitis B is a virus. It's bloodborne, which means it lives in your blood and is passed by blood and other body fluids. It's an infection that causes inflammation of the liver, and it can actually survive outside the body in dried blood for several days. Before the advent of vaccines, hepatitis B killed hundreds of healthcare workers each year. So hepatitis B causes inflammation of the liver. Hepata is the root word for liver, and itis would be the suffix for inflammation. Signs and symptoms: nausea, vomiting, loss of appetite, jaundice, malaise, clay-colored stools, and brown-colored urine. Incubation is up to 200 days, and I think we mentioned already that the mode of transmission is blood, sexual transmission by body fluids, and needle stick injury. It is not expressed in saliva. Criteria for exposure would be a needle stick injury or splatter of blood into the eyes, and it has to be visible blood. So if the patient were to spit into your eyes, it's gross, but as long as there's no visible blood, that is not an exposure. And also blood or body fluids that have visible blood on non-intact skin, for example, open wounds. So it's estimated in the United States about 700,000 to 1.4 million have chronic hepatitis B infection. It is more severe in younger adults under 60 years of age, and in infants it's particularly severe. About 5% of infected adults become chronically infected, which means they have beyond the acute phase, which is a temporary inflammation of the liver, and 95% of the patients with hepatitis B have just the acute phase and then they clear it. But about 5% become chronically infected. Death occurs by liver failure. Prevention: cover non-intact skin, gloves, eye protection, and mask when the possibility of getting bodily fluid splashed or sprayed into your eyes. But the best thing is get vaccinated. Hepatitis B vaccine is very effective and comes in a 3-shot series. Your employer is required to offer this to you upon hiring or applying for volunteering at your agency. So is this an exposure? Your patient has hepatitis B. He's in cardiac arrest. You are performing artificial ventilations with a pocket mask. The patient vomits. Despite the fact that your pocket mask has a one-way valve, you actually get some of the vomit in your mouth. And so the question is, are you at risk for contracting hepatitis B? And so the question that you need to ask is there visible blood in the vomit? So no, unless there is visible blood, it is not an exposure, and you are not at risk for contracting hepatitis B. All right, so hepatitis C is just another variant of a hepatitis virus. Also causes inflammation of the liver. Very similar to the signs and symptoms to hepatitis B. Incubation is 6 to 7 weeks. In the acute phase, acute hepatitis, nausea, vomiting, loss of appetite, jaundice, malaise, very similar to hepatitis B. Estimated that over 3.5 million HCV infections in the United States. Approximately 75 to 85% become chronic. 5 to 20% of those infected with HCV develop cirrhosis, and 1 to 5% die from cirrhosis or liver cancer. So unlike hepatitis B, hepatitis C has no vaccine and there's no cure. Um, Prevention is to cover non-intact skin, prevent body fluids and blood from entering to your bloodstream, wear gloves, eye protection and mask, and using needle-safe devices. So, is this an exposure? You're treating a trauma patient that has a known hepatitis C infection. Your glove rips during the course of treatment. You get blood on your intact skin. So, is this an exposure? No, your skin is intact. You have no risk of contracting HCV or really any of the other bloodborne viruses through intact skin. So this is just a graphic depicting a HIV virus. So HIV is human immunodeficiency virus. It attacks the immune system, leaving the patient unable to fight off the virus. HIV is the virus that causes AIDS, and AIDS is acquired immunodeficiency syndrome, and this is just the set of conditions that result for the patient when the immune system has been weakened. They're very susceptible to opportunistic infections such as fungus infections and bacterial and viral infections that healthy individuals may not get as easy. So approximately 1.2 million cases in the United States. The CDC estimates that 1 in 8 do not know that they are infected. There are about 50,000 new cases each year. There's still no cure. Antiviral drugs have shown great promise in the past 10 years, to the point where some treatments have patients with no virus detectable in their blood. We still call that patient HIV positive, but if the number of viruses are very low in their blood, they are not contagious to a certain point. This is just a picture of one of the opportunistic infections, a fungus that infects the mouth of the patient, and again, that's caused by the immune system is damaged, and they can't fight off these infections. A healthy individual would not get this fungus colonizing their mouth. We would have an immune system that would be able to fight that off. So HIV or HCV transmission via non-intact skin. Just to give you some of the real risk involved with getting blood on your skin. So healthcare workers are at risk for getting these diseases. However, most of them are through needle stick injuries. But just wanted to illustrate some of the concern of getting blood on your skin, blood on your shaven face, blood in maybe the nail beds and that sort of thing. So since 1978, there's actually only been one documented case of a healthcare worker getting HIV by blood on non-intact skin, and that was in 1999. Since 1978, there has been one documented case of a healthcare worker getting hepatitis C by blood onto non-intact skin, and that was in 1999. And that was actually the same worker. The patient was very sick, which means they had lots and lots of virus for HIV and hepatitis in their blood. So a little bit of blood contained lots of virus. And she had open sores on her skin, and the patient was in ICU, and she was treating the patient and got some of his blood into her open eczema, and then she subsequently converted for HIV and hepatitis C. So what is the real risk? We talk about wearing gloves, and that's certainly a practice that I'm not advocating that you change. However, if you were to get blood on your skin, or honestly not have gloves available in maybe like a mass shooting or some situation where you were helping and you got blood on your hands, you treated the patient with no gloves, what is your real risk of getting one of these bloodborne diseases? And the answer is absolutely tiny, In fact, you would have to have an open sore um, to get it. I think that speaks volume that there's in the past almost 40 years that there's been one documented case of that type of transmission. So wear your gloves, wash your hands definitely, but if you get blood on your skin, it's not the end of the world. So tuberculosis is a bacterial infection. It infects the lungs, and we call this an airborne bacterial or airborne transmission because these bacteria can exist in the air in very, very small particles. So we wore very small masks, or not very small masks, but the pores in the mask were very small to keep these particles out of our lungs. Signs and symptoms: bad cough that lasts for 3 weeks or longer, pain in the chest, coughing up blood or bloody sputum, weakness, fatigue, weight loss, no appetite, fevers and chills, and really kind of the hallmark would be the night sweats. And the incubation for tuberculosis is 4 to 12 weeks. So as I mentioned in the past, we wore these masks with very small filters. We call those N95 or HEPA masks. OSHA has actually, in the past few years, relaxed this for EMS. And your book will talk about how N95s are required for TB patients, and that's okay. But don't be surprised if you get into your agency and they don't have these for you, and that's okay. Transmission actually requires contact for several hours, and that's good peace of mind if you ever are exposed to a TB patient. You may not know that they have TB until the hospital calls you and tells you, hey, you just transported a TB patient. So it's a little bit of peace of mind to know that OSHA has relaxed some of these laws or regulations. So if you do have these, you don't have N95 mask available, that's again okay. Surgical mask on the patient if they'll tolerate. If not, put a surgical mask on you. Open your windows potentially if you can do that and it's not too cold outside. And at the very least, turn on your ambulance's exhaust fans. One of the reasons why OSHA has relaxed these requirements for EMS is because the air exchanges in the back of the ambulance at such a great rate that we really have a low risk of contracting tuberculosis. And just a picture from the back of the ambulance, seeing the exhaust vents as well as the HVAC air between those two. You certainly exchange the air in the back of the ambulance appropriately. Just a little difference between latent versus TB disease. If you transport a patient, they have latent disease, you are definitely not at risk. Even if you forgot to do a mask or turn on the air, that just means they have live bacteria in their body, but they are inactive. They cannot spread it in that phase. TB disease or active TB, they have live and active TB bacteria in their body, and this is the patients that can spread it to others. Another disease of concern, meningitis. Meningitis is an infection that of the lining of our brain. We call those the meninges. These can be caused by viral, bacterial, fungal, parasites. Lots of different ways to get infections of the lining of our brain, but the two that we'll run into really that possibly could be transmitted to us would be viral and bacterial. And then even viral is not really that of much of a concern. Really the one we worry about here is bacterial meningitis. Signs and symptoms: fever, lethargic, headache, stiff neck. That's kind of one of the hallmarks of this disease, and then nausea, vomiting. Advanced meningitis, as we get more infection and more pressure into our brain, we would have altered mental status, and then this purple rash, which is also a hallmark of meningitis. Mode of transmission is contact with respiratory secretions. So we're just going to use a surgical mask on the patient if they'll tolerate it. If not, a surgical mask on you and your crew. Really, again, just like TB, this really requires extended contact time. So, surgical mask is plenty protection. A lot of times we'll transport these patients and we won't know that they have meningitis until the hospital causes. Viral really is, if they call you and you've been exposed to viral meningitis, that's not really something that we worry about. The hospital probably won't even call you on that. The one, again, we do worry about is bacterial meningitis. If you are exposed to it, your infection control officer may want you to take prophylactic antibiotics. And hospitals are required to report bacterial meningitis exposures to EMS. All right, influenza is viral. It infects the respiratory tract. It mutates rapidly. That's the reason why we need to get a vaccine each year. Strains are actually named after the proteins on the surface. For example, H1N1, those blue and red blobs on that picture there, that is the proteins on the surface that where they get their name. H is hemagglutinin, and N is neuraminidase, which you don't need to know, but that's just where they get their names. And then you have each variant, so H1N1 is the first variant of each one. And you can definitely get different combinations, H1N3, for example. And again, that's really the reason why we need a vaccine every year. Avian flu, or influenza A, is found in poultry, can infect humans, although it's not very easy to do that. That virus is really primed to infect birds, or even swine flu for pigs. So that virus infects those animals, but doesn't infect humans as well. So really, the people who are in contact with those animals for an extended amount of time and get hammered with just thousands and thousands of viruses, those are the patients that will get it. It's not really transferable from human to human, but we worry that that patient that has avian flu or swine flu, they may also be infected with a human strain, and then those strains can combine and make a new, very lethal strain. So that's why we do worry about avian or swine flu. Just some of the signs and symptoms there. Respiratory infection, so we have a runny nose, sore throats, coughing, even potentially vomiting. And then we have that immune response, so we get fevers and headaches and muscle and joint aches associated with the immune response. Mode of transmission is droplet, and that would be contact with respiratory secretions. For example, in that picture, all those little droplets have the virus in it, and if you breathe those in, you would potentially be exposed to influenza. For droplet, we follow a 3 feet rule, and this is true for all droplet precaution diseases. We follow the 3 feet rule, which means if you're beyond 3 feet of the patient, you are not at risk for contracting it. However, patients in the back of the ambulance, we are definitely in that 3 feet, so the treatment, or the prevention rather, would be to put a surgical mask on them. If not, they won't tolerate it, put a surgical mask on you. There you go. And the best prevention would be get your flu shot annually. I know there's some controversy against this, that, hey, maybe the vaccine doesn't work. But even if it's not a 100% match, it can still confer some immunity to you, and if you do get influenza, it may not actually be as bad of an infection as if you did not get the flu shot. Surgical mask on you or the patient, as we mentioned, and then, of course, with these and with all of these, wash your hands. If that's not available, alcohol. So, not to be confused with the flu, norovirus is viral. It causes the stomach flu. A lot of people call this just the flu, and some people are actually confused about the fact that they got their flu shot and then they get this norovirus, the stomach flu. They thought that they had a vaccine against it, and they wonder why they still got the stomach flu. But it's actually two very separate viruses, not the same thing. This one, the stomach flu or norovirus, infects the GI tract. It is a fecal oral route, which means we come in contact with someone's fecal material, whether they left it on the counter in the bathroom or the door handle or in your food when they prepared it. That's how we get it. Then we put it in our mouth. Highly virulent. It only takes a few virus particles to get you infected, and it can survive on surfaces for days at a time. So we'll talk a little bit about how to disinfect that. It can survive the acidic environment of the stomach. Sudden onset of nausea, vomiting, diarrhea, that's the NVD, and abdominal cramps, and has about a 24 to 48 hour incubation. So if you or someone you know were to come down with this, where were they in the past 24 to 48 hours? You can usually narrow down where they got the virus. And again, just a very small amount of virus can make you sick. In this graph, you got 18 virus particles. I've actually read a study where as little as 6 virus particles were able to infect a healthy individual. And yes, those were volunteers in that study. Compare this to influenza, which takes hundreds or thousands of virus particles to infect you. Just a tiny amount of norovirus can get you sick. Some people may think, oh, it's just a little bit of a nuisance, but 1 in 15 Americans contract norovirus. Up to 70,000 Americans are hospitalized each year. Usually, the older or our young patients may get dehydrated from this. About 800 Americans die each year from norovirus. So it is a serious virus. Maybe not so much death, but it does cause lots and lots of hospitalization, which means lots and lots of money and lots of time lost. So it does. So if you do have it, stay at home and wash your treatment or prevention is washing your hands. There's no vaccine, not yet at least, but washing your hands is really the only way to prevent this. Alcohol hand sanitizers do not kill norovirus. If it can survive in the stomach, alcohol will not kill it. To clean infected areas or surfaces, clean with a 1 to 100 solution of bleach, or a cleaner that has an ammonium chloride in it, for example, Lysol spray. These purple wipes on the side here, we call them purple wipes. They're actually a white cloth inside, but they have a purple top, so we call them purple wipes. That is the correct solution, but I don't recommend these because to really kill that virus, you really have to saturate it with the solution, bleach or ammonium chloride, for at least 2 minutes for it to kill and disinfect your surfaces. So if you've seen anyone clean with these wipes, we kind of just pick them up and kind of lightly wipe the surfaces and then go about our businesses, and it probably stays wet for about 5 seconds. So not enough contact time to adequately kill the virus. Just another thing to be aware of, Clorox brand wipes. Just because it says Clorox doesn't mean it's bleach. So when you're reading the labels, make sure it says bleach or hypochloric acid or contain an ammonium chloride. some Clorox brand wipes have citric acid in them, which is a good disinfectant, but it will not kill the norovirus. Citric acid is what is available in lemons and oranges. So norovirus, highly contagious. Expressed in your you express the virus in your stool up to 3 weeks after infection. So wash your hands after using the restroom. Wash your hands. Get your kids to wash their hands. Everybody wash their hands after you use the restroom, especially if you're in that 3-week post-infection of norovirus. All right, switching gears a little bit. MRSA is methicillin-resistant Staph aureus. Staph aureus is just a bacteria. And so MRSA is a drug-resistant bacterial infection. And in the picture there, you see the little purple staph bacteria. This is just an example of a boil, a staph infection that gets into the skin, overpowers the immune system, and now you have a staph infection in the skin, creates a boil. And that's treatable. Just because it's a drug-resistant bacteria doesn't mean we can't treat it, but we can, like, for example, with Cipro or something like that. But this needs to be addressed lanced and drained in the ER. Antibiotics. Here's a really good one. And another, MRSA. This is just to remind us that we can actually have MRSA colonize our nose. So if you have that patient with MRSA in their nose, you would need to wear them. Another MRSA infection. This is actually treated with maggots, which actually shows some promise on treating some of these drug-resistant bacterial. About 80,000 severe MRSA infections a year. The problem with these is they can spill over into the blood and then make the patient septic, and they're at risk for dying. In fact, over 11,000 patients die each year from MRSA in the United States. The precautions for this would be contact precautions, which means we're going to wear the gown and gloves, and that would keep bacteria off of our clothes and skin while we're treating the patient. If the patient does have MRSA in their mouth, ears, or nose, we're going to wear gloves and mask and eye protection as well. The cleanup would just be to wipe the patient care surfaces. Alcohol hand sanitizer are effective for MRSA. It does not live in the gut. So wiping those surfaces down with any of your disinfectant cleaner would take care of that. A lot of times we don't know the patient has MRSA until after we have transported to the hospital, and that's okay. There's really no prophylactic. Just make sure you clean your skin. Make it a habit after you get off shift to take your clothes off in a certain area and put them immediately in the wash. Just regular cold water wash will kill it. That and all other viruses except for noro. There's no really post-exposure antibiotics that you take for that. Some other viruses that are emerging, Ebola, we talked about that a lot in 2014 and 2015. That is a hemorrhagic fever, which means they have nausea, vomiting, diarrhea, and some patients actually get a bleeding phase where they bleed from different orifices, nose, mouth, gum line, things like that. If they do have the bleeding phase, that's a high correlation with death. And there's not really a lot of treatment or prevention for that, although we are in the process of making an Ebola vaccine. A couple of other respiratory viruses. You have SARS and now MERS, which are pretty much contained uh, to Asia, but they do from time to time make their presence known over in the United States. For those, you would just wear your N95 mask if you have that available. If not, your surgical mask is appropriate, and make sure you turn the air exhaust on in the ambulance to help with airflow. So in summary, there's a lot of diseases out there that we do have concern about that we can catch and that healthcare providers have caught in the past. However, just practicing good PPE and realizing that your risk is actually pretty low, especially for those bloodborne diseases. So really the big thing is to watch out for sharps and watch out for respiratory things. Those are really your two biggest risks. For neuro, make sure you follow strict contact precautions and clean your hands with soap and water, and wash and change your uniform as soon after you have that patient. If you can, at least wear gloves and gowns for any patient you have diarrhea and vomiting. So that's it. Again,